So may I call the next speaker, Dr. Partha? So, as per the list, Dr. Partha is next. Okay, as per the list, Dr. Partha is next. So can I call Dr. Partha, followed by Dr. Leela Bed from Chennai?
Yeah, my presentation is prepared for 15 minutes, what I was given in the communication. I will try to finish it within time. So I think for last 2 hours, what I am hearing is all about from other specialists. Now I'm a nephrologist, and I strongly believe that the complications of the obesity and the diabetes is through the only one organ, it's the nephron. I don't have any anything to disclose, conflict of interest. Some slides I have taken from Medscape Education. So let me start with my real-time patient. A patient came, a 64-year-old Mr. Mishra, under uncontrolled diabetes, hypertension, diabetic retinopathy, heart failure with ejection fraction of 40%, grade 2 diastolic dysfunction, diabetic kidney disease, CKD G3 in form of EGFR of 36 of creatine 2, albuminuria is around 2,859. He had obesity and dyslipidemia. So classical clinical cardiac kidney metabolic syndrome presented with renal dysfunction and cardiac failure. So this patient basically is treated by the cardiologist, endocrinologist independently, and was started on sacubitril valsartan, spironolactone, loop diuretics, and amlodipine, insulin, and linagliptin and glimepiride. So after 3 weeks, patient was presented with in the dry state. Creatine rose from 2 to 3.4, potassium 4.8 to 6.5. Sacubitril valsartan was stopped, spironolactone was stopped, insulin reduced. So CKM is very high incidence and prevalence all over the world, and very high mortality rate. So it is found in the general in the study meta-analysis that around 50% of heart failure patient has chronic kidney disease, and another 23% has worsening renal function in heart failure patients. So whenever there is a increasing albuminuria, increasing creatinine, so the incidence of the admission for the heart failure increases further. So how does it happen? It's because of the when kidney does not work, fluid retention increases afterload, activation of the RAS and increases afterload, which causes the heart failure, and in turn that heart failure causes renal dysfunction and reduced EGFR further. And diabetes basically interplays with this mechanisms in both ways. So epicardial fat, pericardial fat, kidney fat all causes CKD and CVD. Now I want to focus on this slide that in the diabetic and obese patient, there is a vasodilatations of afferent arteriole and larger efferent arteriole causes increased single nephron GFR, glomerular hypertrophy, podocyte injury, glomerulopodocyte loss, glomerulosclerosis, and classical presentation of diabetic kidney disease with hyperfiltration, then albuminuria, then microvascular damage, and glomerulosclerosis. All this we know. And probably that this is going to answer what Dr. Swaraj told, that another is when there is a diabetes, there is the activation of the SGLT2. And another mechanism is because of the hyperactivation of the SGLT2, there is increased reabsorption of the proximal tubular glucose and sodium, which causes hyperreabsorption stress and hypertrophy. And that another alternate phenotype is the remodeling, cellular remodeling, atrophy, and tubulointerstitial fibrosis, where you don't get the albuminuria but progressive chronic kidney disease. And this is the reason the JAMA study, which is presented a few weeks ago, showed that SGLT2 inhibitor across the kidney function, across the albuminuria, works better. So in this slide, you see the middle is the mechanism of the diabetic kidney disease. Now, when you block the SGLT2, there is the reabsorption of the sodium and glucose is stopped, and then there is a reversal of the hyperfiltration mechanism by the macula densa, and then so the SGLT2 basically reverse the arteriolar vasodilatation and hyperfiltration, so we can stop the progression of the diabetic kidney disease. Another molecule, finerenone, non-steroidal MRA, reduces the glomerular hypertrophy, fibrosis, mesangial proliferation, inflammation and fibrosis, tubulointerstitial fibrosis, sodium retention, potassium excretions, and sodium-potassium pump inflammation. So ultimately, it causes basically reduced inflammations and fibrosis of both kidney and heart, and reduction of the cardiac hypertrophy, blood pressure control, improvement in both systolic and diastolic dysfunction. GLP analog also has very interesting mechanisms in the afferent and efferent arterioles. So when we talk about the kidney metabolic syndrome, it has 4 stages. Stage 2 is the commonest, commonly found, and stage 3 and stage 4 is more advanced. Now, if you see the progression of the chronic kidney disease, it depends on the albuminuria and GFR. So, more albuminuria, more progression of the chronic kidney disease, more reduction is the eGFR, more progression of the chronic kidney disease, and that is the reason if you see the brown to red and then dark red area, that basically signifies very advanced kidney disease, and which are correlated with CKM stage 3 and stage 4. So how to prevent eGFR and ACR, and we can do NT-proBNP to find out. Someone was asking about the subclinical heart failure. So how to treat? We treat old age well-trust medicines is ACE inhibitor ARB, and it basically works on the efferent arteriole vasodilatation, so reduce the glomerular capillary pressure, reduce hyperfiltration and renoprotection. On the other hand, SGLT2 inhibitors basically acts on the afferent arteriole, and then the same way it has the renoprotection mechanism. So that is the reason ARB and SGLT2 inhibitor both have additive renoprotection action. So now from the mechanism to real world evidence, credence trials with canagliflozin, DAPA-CKD trial with dapagliflozin, EMPA-kidney trial, everywhere we have seen the improved primary cardio-kidney composite outcome. And when that EMPA SGLT2 inhibitor, when is used across the CKD, it reduces the heart failure incidence. Now, non-steroidal mineral particle receptor antagonists reduce the heart failure admission for the first heart failure incidence, and also repeated heart failure related death or hospitalization is reduced with finerenone. Now we have almost 19,000 patients with all the pooled data of the fine arts and the Fidelido DKD and Figario DKD study, and it has shown that it reduces both cardiac and renal outcome. When GLP-1 agonist is used, it reduces the mortality, it reduces the major adverse cardiac event, major adverse kidney events, and it also is found that major first-time kidney disease events is reduced, major first-time cardiovascular event is reduced, and death from any cause is reduced with GLP-1. Now the combinations of SGLT2 and finerenone, it is found that when it's used together, the cardiovascular death and total worsening of the heart failure event are reduced much more when compared to when they are used alone. Now, NEJM study confidence trial has also shown that when we use EMPA and finerenone separately, and when we use together reduces urinary ACR excretion much more compared to when we use alone. So 2024 KDIGO guidelines, lifestyle modification, then first line medicine is the SGLT2 inhibitor. So someone was telling that how can you find out that why the heart failure, the subclinical heart failure patient or even clinical heart failure patients we are missing. Probably if you use these guidelines, then SGLT2 inhibitor and finerenone will be used as a preventive medicine than as a treatment. So probably we will be able to prevent heart failure, and that will help us in many ways. So earlier we used to treat single-handedly, but the St. John's Hospital, George Hospital in London has used this team approach, and that has found that personalized care and guidelines directed medical treatment, newer therapies, coordinated care, timely care, reduce inequalities, and educate the patients and educate the staff. So when this particular patient, when we all the consultants discussed together, we changed the treatment and we changed his diet first. First is the low calorie, low salt, low fluid and low potassium diet, and then we added dapagliflozin, we added semaglutide, we have switched over from amlodipine to cilnidipine, though it is not the part of the KDIGO guidelines, we can discuss separately. We added finerenone, we added low dose sacubitril valsartan, atorvastatin, ezetimibe, we have stopped rosuvastatin, we have stopped sulfonylurea, we have removed the DPPI inhibitors and amlodipine and reduced dose of insulin. I don't like insulin because insulin does much more damage than other medications. So the same experience in Canada also, when the consultants see independently, the treatment protocol is delayed. So they have formulated Decide CV program, and when all the consultants work together and for follow-up. So
Can
they
I ask
have
you to
found
summarize and conclude?
that SGLT2 inhibitor usage, GLP-1 receptor usage, RAS inhibitor usage, and MRA usage are much more when all the consultants sit together and decide. And these most of the drugs which we are commonly used are reduced less. So from my take-home message would be the nephron is the central part of the pathogenesis of the cardiac kidney metabolic syndrome from diabesity. Hence, treatment is to target the nephron, and interdisciplinary collaborations is essential to successfully implement life-saving therapies that fundamentally improve patients' outcome and quality of life.
Thank you very much. That was a very lucid and evidence-based presentation, and you maintained the time also. Thank you so much.
Thank you, sir.
So I hand over the chairing to Dr. Moses.